Hi, good evening, ladies and gentlemen, and welcome to our fourth Clinician's Choice webinar. It's great that you could all join us this evening. I'm sure Peter's no stranger after having him in South Africa at our congresses, having him present all these webinars, and also being an ex-South African himself. So without further ado, I mean, we've been through Peter's CV so often, but his wealth of knowledge with regards to dentistry, the years he's been in the industry, having traveled to 20 countries around the world, training everyone from dentists to universities to dental assistants. I'm going to hand over to you, Peter.
Thank you, Sharon. Appreciate the introduction, and again, appreciate the opportunity to share with you folks. We're going to dive into impression material today, and just kind of share with you what's different and how it can help you reduce your treatment time, increase your efficiency, and ultimately increase your practice profitability. So we're going to just go through a PowerPoint, and then we will. I will just switch over to the Epson visualizer here and just demonstrate some other things that I'm sure will be of interest to you. So. Share. Okay.
Share screen. Your screen and then share. And open up your PowerPoint.
Okay. So can everybody see the PowerPoint presentation?
Yes, Peter.
Okay.
Yes.
Perfect. Okay. So the topic of this webinar is consistently accurate impressions. And there are a number of key success factors that one has to take into account to ensure that we can get an accurate and predictable result. Number one is we need profound hemostasis. We need that area that's going to be, where the impression is going to be taken, to be free of any sort of sulcular fluid, blood, any contaminants. Now, typically when you're doing your crown prep, are you either using a high-speed diamond or carbide burr? Many times you create what we refer to as a smear layer. And many times people think if you just use your air water syringe, you can remove that smear layer. But you really need something that has a mild acid because you cannot remove it with your air water spray. So we have a little product called Detail. It's a pre-impression cleansing gel. It's a 10% EDTA, ethylene diamine tetraacetic acid. And why did we only go for 10%? Is we needed a mild acid to remove those contaminants, but we wanted to leave the dentin smear plugs intact because we didn't want to induce any sensitivity during the final cementation of the restoration. So with this, it's applied with a little brush tip, and you literally scour the preparation site for about 7 to 10 seconds. You rinse it. And it does two things. Not only does it leave that prep site squeaky clean, but it also lowers the surface tension, meaning that your impression material can more intimately contact that preparation site for a more detailed and accurate impression. Now, dentists have asked me, can I use my chelating and lubricating agent, something like a file ease or a product, I think that's probably from Alport, but the challenge with those chelating and lubricating agents is they're too aggressive because they all contain about 17 to 18% EDTA. So the benefit of Detail, as I said, it's only a 10% EDTA formulation. Now, it's also important to select the correct tray for your technique, and then to also select the correct viscosity of material for that particular technique, and then to make sure that your impression material matches the tray. Now, the challenge with many manufacturers is they make different viscosities of impression material, but they're not necessarily technique designed. And I'm going to share with you why it is important to be using an impression material that is technique designed to ensure that you're going to create dimensionally stable, accurate impressions. So really, what are the goals of a dental impression? Well, there are a number of goals. And the first one is to accurately replicate the patient's dentition, both arches. We need to make sure that we capture the margins, the preparation margins that are free of voids or air bubbles. And I'm going to share with you something, how you can avoid this when we switch cameras. We want to make sure that the tray is not exposed through the impression material. And if we're using a quadrant impression tray, we want to make sure that none of the mesh is exposed through the impression material. This is key. We need a seamless blend between the light body and the heavy body material, or the tray material, if you will. And most importantly, and this is where many impression materials fail, is we need that entire preparation site totally encompassed in light body. You know, many times I ask clinicians, why are you putting all this light body around the preparation site when you look at your impression, it's only captured in the margin? There's a reason why you want that entire preparation site completely captured in your light body material. And then we need dimensional stability and accuracy. The most critical factor of impression taking is dimensionally stable. When your impression material and your tray are more dimensionally stable, the result will be something that's more accurate. But there's also a number of factors that we need to bear in mind when we look at the laboratory. What does the laboratory require when they receive an impression from the clinician? Well, number one, they need rigidity and stability of the tray and the impression material. They want to make sure that there is an adequate tooth reduction required for the desired prosthesis. So many times they will ask for 2 millimeters of reduction and pray that they get 1.5. They have to have the ability to clearly read the impression margins. And then especially if they've taken a full arch impression, they need a detailed opposing arch impression. They need the ability to disinfect the impression, and now more than ever. And this is where some of the formulations in the industry fall short. So if you're using something like that is truly hydrophilic, like polyether, or if you're using something like hydrocolloid, they are truly hydrophilic. So the challenge with that is they will absorb that moisture, and dimensionally that impression will change. The lab also requires from that same impression to do multiple pours. So again, this is where truly hydrophilic impression materials fall short. Because again, dimensionally it's going to change that impression, so that when those crowns come back, you're either going to have to be adjusting them for them to get them to seat properly, or they'll be like a rooster wearing socks because there's so much additional space. We need an accurate bite relationship, and then an accurate prescription. And what I mean by prescription is the communication between the dentist and the laboratory is vital to ensure a optimum result. And why? Well, first of all, we know that all impression materials shrink just a little bit. So it's important that the laboratory knows what type of impression material the clinician is using. Then additionally, did the clinician disinfect the impression prior to sending it to the lab, or does he require the lab to disinfect the impression when they receive it? Because if you're disinfecting the impression prior to sending it to the lab, and then the lab's disinfecting the impression, especially if you're using some of these materials that are truly hydrophilic, dimensionally that impression is going to change, and that will have an effect on the final result of the prosthesis. And the reason why laboratories need to know what the shrinkage percentage of your impression material is, because they need it to match to the expansion of the die stone materials, because we want to make sure that there's just a little bit of space for the cement. So we want the expansion just to be slightly greater than what the shrinkage percentage is of your impression material. So, if we look at indications of compromised impressions, what do they look like? And this is some of the images that have been sent to me by laboratories of what they receive. So, typically an indication of compromised impression means when typically the lab has to apply coats of dye spacer to the model to ensure that that crown is going to seat properly. And typically when the crown comes back, if you, the clinician, have to spend time doing interproximal adjustments or having to do occlusal adjustments, that's typically a result of a compromised impression and or the tray that you might be using. So when we look at some of the common impression challenges, in this case here, they've taken a heavy body impression first, and then they've taken a separate light body impression. Now the challenge with that is, first of all, it's time. Secondly, the occlusion for almost certain be high. And then there's also the issue of delamination between the tray material and the wash material. In this situation here, the heavy hydraulics of the tray material have over displaced the light body material. So you can just see the light body here is just primarily in the margin. And that is a compromised impression. Again, there will be issues with seating of the crowns and adjustments that will be required to be made. In this situation here, you can see that there was a significant amount of blood in the preparation site, and also the clinician here didn't even use an intraoral tip. So you cannot, it's very difficult even to see a margin in that restoration. In this situation, the patient has clenched down too hard. So here you can see the mesh is exposed through this. So the occlusal and lab to create something that's going to go into perfect occlusion is extremely difficult. Here, the arch width of this plastic tray is too narrow, so you can see that it's compromised the impression right here on the margin, because there's the tray wall of that plastic tray. Here, in this situation, the clinician has exceeded the working time of the impression material. So you see you've got drags and pulls in the impression. And then finally, here, in this case, this impression would have to be retaken, because there's absolutely no margin here for the lab to create a predictable result. So with cases gone wrong, who is at fault? Well, let's look at the research and what the research shows. Well, the research says in order for a crown remake, 22% of the time it's laboratory error, and 78% of the time it's clinician error. And that's because of either the tray and or the material that is being used. So when we look at the ideal impression material, what are some of the key characteristics that it should have? Well, number one, it should be fast. Okay, it should have quick working time with a quick set time. Why? We know that the longer the impression material is in the mouth, the higher the potential is for distortion. We need something with no taste. It makes no clinical sense to be using a material with a scent or a flavoring in, because all it's going to do is it's going to stimulate the parasympathetic nerves and increase salivation. And really, the goal when taking impressions is to have that preparation site as dry as possible. Obviously, we need something that's going to provide exact detail. We need a material that's dimensionally stable, because when your impression material is more dimensionally stable, it will naturally be more accurate. We need the preparation site that is totally encompassed in wash material. And I'm going to share with you momentarily why that is so important. Obviously, we need easy color to read the margins. We need a variety of technique-driven viscosities. This is very, very important to assure an optimum result. We need to have the ability to disinfect these impressions, especially now with COVID. And then, of course, for you folks, it needs to be cost effective. So what types of impression materials are available? Well, when we look today, the majority of the market is using vinyl polysiloxane or polyvinyl siloxane. There's still a fair amount of polyether used out there. A little bit of hydrocolloid. We find that prosthodontists typically like this material because it's extremely accurate, but on the flip side, it's a very, very technique-sensitive material. And then a little bit of polysulfide rubber and a little bit of condensation silicone. So when we look at truly hydrophilic impression materials, unfortunately, there's a lot of marketing out there which is not entirely true. And I'm going to share with you that typically most polyvinyl siloxanes are not hydrophilic. They add something to the formulation that will allow them to perform better in a moist environment, but they are not truly hydrophilic. The only truly hydrophilic impression materials are hydrocolloid and polyether. But the property of these materials to be able to absorb or lose water can lead to dimensional instability. So let's look a bit more closely at polyether. Improgum is not a bad material, folks. It's been around for a lot of years and it has a proven track record. But, I also mention to people that over the last 30 years, they've certainly made some improvements to some of the other materials available. So again, not that it's a bad material, but we all know that anybody that's had polyether in their mouth, it doesn't taste very nice. It's got a pretty nasty smell. It's not as dimensionally stable as vinyls. It has a long intraoral set time. And again, the longer the impression materials in the mouth, the higher the potential there is for distortion. Then it sets quite rigid. So sometimes that can be difficult to move, especially if you have an undercut. There's a high probability that that material can tear because it has relatively low tear strength. Unfortunately, it's not recommended that these be disinfected because they will absorb the water, the moisture in that disinfectant, and they will dimensionally change. The same thing with pouring up models. You can only pour it up once because when you pour it up again, it's going to pull that moisture out of the stone mix, and dimensionally it will change. And then the catalyst is epamine. And epamine, if exposed to bone, can cause necrosis. Especially if you've got clinical situations where that does exist, then just err on the side of caution. And then we all know that polyether isn't inexpensive, so you also got to look at trying to be as profitable as possible. So we're talking about hydrophilicity. Hydrophilicity is a buzzword that appeared in the mid-'80s. By adding surfactants, we've been able to improve the wettability of these materials, but it doesn't make them hydrophilic. Okay. So why choose a PVS or a VPS impression material? Well, the reason is they show the smallest dimensional changes on setting of all elastic materials. So it's a 0.05 to 0.1% reduction in volume due to polymerization. And it's matched to the linear expansion of your type 3 and type 4 die stones. As I said, you want that slightly larger die because you need just a little bit of space for that cement when you cement that crown. So why should the entire preparation site be totally encompassed in wash material? So this is the type of the situation you want, where that entire preparation is totally encompassed in wash material. And the reason being is that typically when you send your impression to the lab, depending on the clinician, they'll know for Dr. Smith, they'll put on 4 coats of dye spacer, or for Dr. Jones, they put on 5 coats. Well, we know that with your light body materials, you get about 3 to 7 microns of accuracy. With your tray putty materials, you only get between 45 to 55 microns of accuracy. So now, when you're adding 4 or 5 coats of dye spacer, every time you add a coat of dye spacer, you're adding another 8 to 10 microns in film thickness. And now all of a sudden you've created if you've got 4 or 5 coats on there, and all your light body has been over displaced, you now at 100, 120 microns of film thickness. And that's a big challenge because according to the research, we lose cementation strength once we increase the amount of the thickness of the cement. And according to 3M, this is the research done by them, the cement gap of a typical crown and the tooth is between 80 to 120 microns. Well, optimal crown seating occurs when 40 microns of space exists between the tooth and the restoration. Why? Well, all resin-based cements are between 2 and 20 microns thick. So when you go beyond 40 microns, you lose the cementation strength and longevity. And hence, the analogy that I use is if you put in tile in your kitchen or your bathroom, if you put that tile too far apart, what happens to that grout? What happens to that cement after a period of time? This is what happens, right? Because remember, we've got more bacteria in the oral cavity than anywhere else in the human anatomy, and that bacteria is very, very acidic. And eventually what it will do is it will start breaking that cement down. And, you know, on occasion, you'll see people walking around with permanent restorations where they've got a dark stain right at the margin. Now, this was more prominent, especially with PFM crowns because of the oxidation of the metal. But you also see this happening with lithium disilicate or zirconia crowns. Is again, if the cement is too thick, that bacteria over a period of time will break that cement down, and hence the reason why sometimes crowns fall out prematurely and they have to be re-cemented. So if we look at polyvinyl siloxanes and how they've evolved, is typically the first generation of a polyvinyl siloxane was what we referred to as a linear polymer. So we had these polymer chains, and at the end we had these little reactive ends, and they grab from one end to the other end. But the challenge with these is, number one, the first generation had very, very limited viscosity options. They didn't perform very, very well in a moist environment because there was no surfactant in the formulation. They had long intraoral working and set times, and they weren't dimensionally very stable. So they introduced second generation, and this is what the majority of the vinyl materials are today. Second generation. And what they simply did is they added surfactant to the formulation. And what a surfactant is, it's a moisture displacing agent. It helps to kind of displace that moisture. So for argument's sake, if you washed your car and you looked at the profile of the water droplets on the car, they would stand up quite tall. However, if you washed your car, then waxed the car and then sprayed water in the car, you'll notice that the profile of those water droplets would be much, much lower. And that's essentially what a surfactant does, is it just helps to displace that moisture, if you will. So these are many of the manufacturers out there. Again, nothing bad about these, but when you look at all of these impressions, look where all the light body is. All the light body has been over displaced at the preparation site. So then what some of these manufacturers did is they created what they refer to as these suprahydrophilic impression materials. And all they did is they added more surfactant to the formulation. But the challenge with these, and these are some classic examples, was a product called Splash and a product called Precision, is all of that was just simply marketing bullcrap. Because when you look at the research, you know, what does the addition of surfactants do to VPS materials is all it does is the more surfactant you add to the material, the more the material will not cure to 100%. So, and if the material doesn't cure to 100%, it's not going to be dimensionally stable. So, you know, the catalysts that are typically are in vinyls is platinum, and so and that's why there's never an issue if you have a patient with necrosis, because unlike polyether, which has epimene in it, it's not going to be an issue. But the issue by adding additional surfactant to the formulation is the more you add, the less the material is going to cure to 100%. So which impression material should you be using and why? And this is where we're going to introduce the affinity range for you. Okay, this is not, we don't call it a hydrophilic material, we call it a hydroactive impression material, meaning that it's going to perform well in an environment that is not completely dry. So if you still have some circular fluid, it will perform well. But there's some significant features of this material that make it unique. Well, number one, it is a branched resin chemistry. And I'm going to show you in just a second, we'll go into more detail about each of these features. But with this material, typically most vinyls consist of a filler and a surfactant. But what we introduced is we introduced resin. So we have an ideal blend of surfactant, resin, and filler. And the addition of resin is it ensures that the fluid states between the different viscosities are matched, meaning that your more rigid and dense tray material is never ever going to over displace the more fluid light body wash material, if you will. Then all our viscosities are technique designed. So depending on your technique, we would recommend a viscosity of material. And then our working time is independent from our set time, meaning that we have short working times with short set times. Because again, the longer the impression is in the mouth, the higher the potential there is for distortion. So when we look at this from a chemical standpoint, this three-dimensional branch resin is we have the difference with the three-dimensional branch resin versus the linear polymer is this reactive end grabs here, that reactive end grabs there, that reactive end grabs there. So again, it creates a material that's a lot more dimensionally stable. So a linear polymer would be like a handshake. If you lean backwards and I lean backwards, something's got to give. Where this is more like if you spread your fingers and then you interlock them and then try to pull back, you'll find that this is something that's more dimensionally stable. And I'll show you when I switch cameras. Because we know the most critical factor of impression taking is dimensional stability. And in the research that was done, albeit a long time ago, by having this three-dimensional branch resin chemistry, it makes the material have a superior tear strength when compared to other materials. And I'm going to show you with our weakest light body material, which has a viscosity like water, it's virtually impossible to tear this material. And then our working times are independent from our set times. So what I mean by that is with our regular set material, we've got a 1:45 working time with a 2:30 set time. However, if you were ready to place that impression material in the mouth after, say, 1 minute, you would not have to wait for that additional 45 seconds of unused working time to expire before the material starts to set. As soon as you seat the impression in the mouth, the material is heat activated, and you would set your timer for 2 minutes and 30 seconds. And then we have a fast set material, which is a 1:10 working time with a 1:45 intraoral set time. So you can see compared to many of the competitor materials, just in our regular set material, you can see that we have shorter working times with shorter intraoral set time. Because as I said, the longer the impression materials in the mouth, the higher the potential there is for distortion. And then we have these technique design viscosities. So depending on your technique, we will match a impression material to that tray so as to reduce any sensitivities with your impression taking. Then what we have, which is very, very unique to the industry, is we have what we refer to as spectrum packs, which allows you, the clinician, to mix and match and self-customize for your office. Because typically when you buy your impression material, you either have to buy 6 of this viscosity or 6 of that viscosity, but we know the ratio of tray to wash material in a full arch tray is about 4:1. You're going to use about 4 times more tray material than you'd use wash material. And in a quadrant tray, it's about 3:1. So what this allows you to do, this allows you to buy the appropriate quantities of the materials that you're using all your materials simultaneously. So in these, you can put light body, you can put heavy body, you can put a little bit of monophase if you're doing primarily, if you're doing, say, edentulous or partial impressions. You can put in bite registration, but you can buy it in quantities where you're using all the materials simultaneously. And there's no other manufacturer that does this. So when we look at the different viscosities of material, we have 3 different light bodies. We have 2 tray materials. We have a monophase material. So for anybody that's doing single phase impressions, that's where we would recommend a monophase. We have a very, very unique bite registration material called Quick Bite. Again, the challenge with most bite registration materials is to get the high durometer. You have to add a lot of sand, a lot of silica to the formulation. But the challenge with that is it makes them extremely brittle. So many times when you try and trim them, they tend to crumble. Or if you have an undercut, they tend to break very easily. But by incorporating resin in our formulation, this gives the material the ability to be trimmed and carved without that happening. And we were also able to make it with a much, much higher durometer. Durometer is how hard the material is, and typically most bite registrations are at about 80 to 85, but the challenge with that is sometimes you can get compression on articulation in the laboratory. And that's why sometimes when the crowns come back, you have to spend time adjusting the occlusion. So by having a material that has a 92 durometer, it makes it extremely rigid so as to prevent that compression on articulation at the lab. So, let's look at the different techniques to use to take impression. So typically, for a full arch impression, you use a putty or heavy body material with a light body material. And this is where we would recommend our heavy body material with one of our light body materials. Now, typically the light body material we would recommend the majority of the time is this blue material. This is our light body high flow. This material, when you seat the tray, the hydraulics of the tray material will automatically push the light body up into the sulcus. Then for quadrant trays, we developed the only tray material in the industry specifically designed for use in a quadrant tray, and that's our Inflex material. It is more rigid than any putty or any other competitor's heavy body material, but I can, and I'm going to show you, get this material to flow through an intraoral mixing tip. You would never use it that way, but I just want to show you how, with the addition of resin to the formulation, it allows these materials to have these matched fluid states, so that to prevent the light body material from being over displaced out of the preparation site, if you will. And typically in the research that was done back in 2007 by the ADA, they said if you are using a quadrant tray, the tray material you should be using in there should have what referred as a straining compression of less than 2%. Now, the nice thing about Affinity Inflex is that it has a strain compression of 1.3%. So really, you need a rigid material to provide the support of the walls of the impression tray. And this, you can see, all these materials here are all above 2%. So they're fine to be used in a full arch tray, but certainly would not be recommended to be used in a quadrant tray. So let's look at our different viscosities. So this is our light body extra light. This is not something that you use routinely, but in clinical situations where you've got a sulcular depth that's less than 0.2 of a millimeter, typically no matter what form of retraction you use, that tissue tends to go back very quickly. And so now, as to prevent a void or an air bubble in the impression, or more frustrating, when you remove the impression, to prevent it tearing from at the finish line, this is with our three-dimensional branch resin chemistry. This material will help prevent that from happening. Then, as I said, this is the light body high flow. This is the one that I would recommend that people use the majority of the time. Again, with the hydraulics of the tray material, this will just push the light body up into the sulcus to make sure you get a nice, accurate impression. However, there are some dentists that like to use their air syringe to blow the light body into the sulcus, and this is where we would recommend our light body regular flow. This is just a little bit more viscous material. I know that this technique is not used as much as it has been in the past, but there are some dentists who like to take their air syringe and blow that light body into the sulcus. Then for single phase impressions or partials or edentation impressions, this is where we would recommend our monophase. This is a material that's most similar to polyether, but with some clinical benefits. It has the same gum-like consistency to polyether, but it has no taste, it has no odor. You can pour this up multiple times from the same impression. You can disinfect the impression with this. It has a shorter working and set time. So the working time of this material is 2 minutes and 15 seconds with the intraoral set time of 2 minutes and 45 seconds. So this is a material that people that have switched from polyether typically switch into our monophase material, if you will. Now, I know there's many dentists that for many, many years have used putty. Well, why is putty, putty had its place many, many years ago, but why is putty a poor option today? Well, number one, putty has to be hand mixed. So typically, if your assistant's wearing gloves, they have to remove the gloves because, especially if they're wearing latex gloves, they contain sulfur. And sulfur contamination is one of the reasons why materials don't set completely. And then the other challenge with putty is they are so filler dependent that they tend to over displace the wash material. So you can see here in this impression, the orange material is the wash material, and it's been completely over displaced out of that preparation site. Now, for people that are diehards that want to use putty, we do have a putty available. The difference with our putty is it's a little bit more of a satiny, smooth formulation. So what it allows you to do is it allows you to create a nice feather edge at the interface. But we don't sell a lot of it. As I say, there are some dentists that are just will not change from putty, so we do have a putty available for those folks. So from a PowerPoint standpoint, that's kind of it, and I'm just going to switch over to the camera now. Let's go to scope.
Minimize or close, whatever.
Okay. Share screen.
Camera app. Yep, share.
I'll share first.
No, share screen.
Okay.
Click that, and then share. And now bring up the camera.
Okay.
No problem.
No?
No, it is right.
Okay. So, just going to zoom in here a little bit. So, what I really want to show you here is this is our inflex material, but what I want to show you, this is all a single step impression where the clinician has syringed the light body around the preparation site, and then the assistant has loaded the tray. But you can feel, I mean, you can't feel this, but this material is extremely rigid. But there's a couple of things I want to point out to you is with this material, because the fluid states of the material is matched, and you can tell the reason why this is why it contains resin. If you look at most impression materials, they kind of have a matte type of finish where you can see this is shiny because that's where we've incorporated resin. So when I think of resin, I think of flow. But when you look at the interface between the light body and the heavy body, let's see if I can zoom in here a little bit more. You will see that that blend is seamless. So there's never going to be any issue with delamination. The other thing that I would recommend is that to prevent voids or air bubbles in the margin, is when you're going around the preparation site with your intraoral tip, is never start on the margin and never finish on the margin. Start on the side and come up into the margin and then over the entire preparation site. And when you finish, pull off, don't pull off on the margin, but come a little bit past the margin and then pull your tip off. And you'll find that you will have less issues of having air bubbles in the margin of your restoration. And then this is our heavy body, our tray material. Again, you can see that blend between the heavy body and the light body is seamless, and that entire preparation site is captured in the light body material, meaning that you're getting 3 to 7 microns of accuracy versus 45 to 55 with all the tray material. If it had exposed all the light body material, you just had the tray material. So again, because a crown seat, folks, shouldn't be taking you more than 8 minutes with an X-ray. You know, if you're booking a half an hour to 45 minutes, you think about it today more than ever, that time is of the utmost importance. So, you know, if we can eliminate you having to do these adjustments to get the crown to seat properly, then it's going to certainly help your profitability of your practice. And then this is our monophase material. As I say, this has got the same gum-like consistency like a polyether, but as a shorter working and set time, is more dimensionally stable, because as I alluded to earlier, I'm just going to zoom out here, all the other impression materials are linear polymers, which is like a handshake, whereas our three-dimensional branch resin is more like this type of analogy. So again, if I take our weakest material, which is our light body extra light, and this has got a viscosity like water, I can take this, and again, if I try and break it, I can't break it. Now, obviously, I'm not going to try to tear it, because that's not going to happen clinically. But it is I can take competitors' light body material and I can get it to snap, and I cannot. Again, I'm not pretending. I'm pulling as hard as I can, and I cannot break this material. And this is our weakest material. Then, as I mentioned earlier, this is our inflex. This is the material that we use in the quadrant tray that is more rigid than any competitor's tray material. And although clinically I would never ever use it this way, this material I can get to flow through, because typically I would use it through a 6.5 mixing tip because we're loading the tray, but I can get this material to flow through an intraoral tip. And this is just to show you folks the resin component in this material, which again allows the fluid states between the different viscosities to be matched. And I can assure that if you take any competitor's heavy body material, you won't be able to get it to flow through an intraoral tip. And then just to show you the bite registration material, again, the thing with bite registration materials is when you're testing them for durometer, most people want to take them and bend them. Well, that never happens clinically because remember, you're closing into occlusion. So typically, what I always encourage people to do is see if you can compress the material. Now, because this has got such a high durometer, there's going to be no issues with, as I say, compression or articulation at the lab. And then if I trim this material, unlike many bite registration materials that will crumble, this just simply carves like butter. So there's never ever going to be any issue with you now having to retake a bite because it's crumbled and it's brittle and it's broken. And that's about as mean as I'm going to treat you. I don't know if there's any questions, Sharon. How do we get out of here? So I don't know if there's any questions that anybody has, Sharon, that we can take.
Peter, not at this point. If I could ask the delegates, should you have any questions, to post them, but also to visit our polls that have been posted and vote. It just gives us an indication as to what we need to do, to either improve our webinars or if you need any additional information. So yes, if I could ask all of you to just please visit the polls, it will be to the right of your screen, and just answer 3 questions there. But Peter, I think you've covered everything because there are no questions.
Okay, all righty. Well, I hope it's been helpful. I mean, the philosophy of our company has always been, in the 35 years that we've been in existence, is teaching better dentistry. And really to try and understand the clinical challenges that clinicians face every day. And then armed with that knowledge, we work very, very closely with a lot of evidence-based key opinion leaders. So typically, all of our products get independently clinically evaluated before we bring them to the market. We don't use you folks as the guinea pigs until we've got something that's figured out. So again, for the people that do use Clinician's Choice products, we appreciate your business and support. And we are currently looking at bringing new products to market that have been evaluated first. So we are broadening our range of restorative materials. Now, I didn't say anything about digital impressions, and I think is it the way of the future? Absolutely no doubt about it. But there's still a large percentage of you folks. We know in most markets more than 80% of dentists are still using impression material, and a properly taken impression, is as good as a digital impression, in my opinion. And there's when many of these manufacturers say, well, once you go over to a scanner, you never have to take another impression again. That's not entirely true either. So again, I caution people to challenge the people that walk through your doors to say, okay, where's some of the research that supports some of the claims that you're making? Because many people will try to sell you something based on marketing and hype. So on that note, I'm going to say thank you again. I appreciate the opportunity. I know we've got another one in a couple of weeks on provisional restorations. So if you haven't signed up for that, I would encourage you to do that. Again, this is one area of our company where we've spent a lot of time in developing materials that can reduce your treatment time, because especially with temporization, is typically you're not billing the patient separately. And now, especially with COVID, if you can have something, you can fabricate crowns in about 8 to 10 minutes. That can be very beneficial for you. Even if you're having your assistant doing it, you're still paying your assistant a salary. So, I hope you will tune in for that. And I think it's November the 11th.
Peter, I've got a message here for you from Dr. Barry Bailison. He says, excellent lecture, Peter. Regards, Barry Bailison.
Thank you very much.
And Dr. Martinez Mulek, very interesting. So thank you, Peter.
Very, very welcome.
So from all of us in sunny South Africa, stay warm in cold Canada.
Thank you.
And to our delegates, we look forward to seeing you at our next webinar. Thank you very much. Cheers, Peter.
All right, have a good night, folks. Thank you so much.
Bye-bye.